Welcome to Pulse and Pressors, where critical care gets crystal clear. CVP represents the pressure within the thoracic vena cava, or right atrium, and is often mistakenly used as a surrogate for intravascular volume. In reality, CVP reflects venous congestion and right-sided filling pressure far more than it reflects blood volume. It is heavily shaped by intrathoracic pressure, right ventricular compliance, and venous tone. Because of this, CVP cannot reliably predict preload or fluid responsiveness. Its true power emerges only when interpreted alongside the waveform, where the A, C, V waves and X, Y descents reveal atrial mechanics, tricuspid valve function, and right-sided pathology. CVP physiology is best understood through the Guyton venous return model. Venous return is driven by the pressure gradient between the mean systemic filling pressure, MSFP, and CVP. The larger the MSFP minus CVP gradient, the greater the flow returning to the heart. CVP rises when RV afterload increases, when the RV fails, when intrathoracic pressure increases, or when fluid is trapped by pericardial constraint. CVP falls with venodilation or hypovolemia. In Guyton's model, CVP is the pressure at which venous return and cardiac output curves intersect, making CVP a marker of congestion, not preload. Decades of research confirm that CVP does not predict fluid responsiveness. It does not correlate with end diastolic volume or stroke volume. A high CVP does not guarantee fluid intolerance, and a low CVP does not guarantee fluid responsiveness. Instead, fluid responsiveness depends entirely on where the patient lies on the Frank-Starling curve. Static pressures simply cannot assess dynamic preload responsiveness, making CVP unsuitable for guiding fluid resuscitation. When used correctly, CVP becomes a powerful tool for diagnosing venous congestion and right-sided pathophysiology. A rising CVP with falling cardiac output, or MAP, strongly suggests right ventricular failure. A sudden rise with loss of respiratory variation points toward tamponade. CVP is also useful in evaluating venous return limitations such as massive PE or severe pulmonary hypertension. Most importantly, the trend of CVP is far more informative than any absolute number. The CVP waveform is the true diagnostic treasure. The A wave represents atrial contraction. It disappears in AF. The C wave reflects tricuspid valve closure and slight bulging into the atrium. The X descent is due to tricuspid annular downward movement and atrial relaxation. The V wave represents passive atrial filling, normally modest in size. The Y descent indicates rapid atrial emptying during early diastole. Abnormalities include large V waves greater than 10 millimeters of mercury in tricuspid regurgitation, giant A waves greater than 10 millimeters of mercury in tricuspid stenosis or RV noncompliance. Understanding these values allows clinicians to quantify disease severity. Waveform patterns reveal disease states. Giant A waves suggest tricuspid stenosis, RV hypertrophy, pulmonary hypertension, or RV infarction. Cannon A waves occur when atria contract against a closed tricuspid valve, typically in AV dissociation, such as VT, or complete heart block. Prominent V waves indicate severe tricuspid regurgitation, where systolic backflow elevates atrial pressure dramatically. A blunted X descent suggests pericardial disease or atrial fibrillation. A blunted Y descent may indicate tricuspid stenosis, restrictive cardiomyopathy, or tamponade. In constriction, a sharp Y descent followed by plateau forms the square root sign. These patterns transform the waveform into a diagnostic instrument. Respiratory variation provides additional diagnostic clarity. In spontaneous breathing, negative intrathoracic pressure during inspiration should lower CVP. In positive pressure ventilation, inspiration raises CVP. When normal variation is lost, think tamponade, stiff RV, or excessive PEEP. When variation is exaggerated, suspect hypovolemia, or marked RV sensitivity to pressure swings. Respiratory phase interpretation is essential for accuracy. CVP pitfalls are common. High PEEP artificially elevates CVP by transmitting pressure into the thoracic veins. Dynamic LVOTO, despite poor forward flow, can produce deceptively low CVP. Severe tricuspid regurgitation produces large V waves, making mean CVP unreliable. Interpretation must rely on waveform shape instead. Atrial fibrillation removes the A wave entirely and flattens the waveform. Mechanical ventilation changes timing and amplitude of waves. Without understanding these influences, CVP becomes misleading. Accurate CVP measurement requires strict technique. The patient must be positioned supine or with the head of the bed 0 to 45 degrees, and the transducer zeroed at the phlebostatic axis. CVP must be read at end expiration during spontaneous breathing or end inspiration during mechanical ventilation. Waveform interpretation should supersede digital mean values, particularly in tricuspid regurgitation. High PEEP must be corrected for. Subtracting about half of PEEP approximates transmural CVP, which better reflects true filling pressure. Integrating CVP with VEXUS dramatically enhances diagnostic precision. VEXUS assesses congestion through VC size and venous Doppler abnormalities in hepatic, portal, and intrarenal veins. Grade 3 congestion, IVC dilation, with greater than or equal to 2 Doppler abnormalities, is strongly associated with AKY and organ dysfunction. A high CVP plus VEXUS grade 3 identifies patients requiring aggressive decongestion. CVP alone cannot provide this specificity. CVP should guide clinical decisions only when paired with other physiology. High CVP with low cardiac output points to RV failure, tamponade, or PE. Fluids will worsen the situation. High CVP with normal cardiac output indicates congestion or TR and suggests diuresis. Low CVP with low cardiac output requires dynamic assessments such as passive leg raise, PLR, positive pressure ventilation, PPV, or stroke volume variation, SVV, to determine fluid responsiveness. Normal CVP with low cardiac output points to left ventricular failure or distributive shock. CVP is useful only as part of an integrated hemodynamic assessment. Special populations require tailored interpretation. In ARDS, high PEEP elevates CVP artificially. Post-cardiac surgery, CVP is typically elevated due to fluid shifts and RV stunning. However, a sudden rise should prompt evaluation for tamponade. Pulmonary hypertension chronically elevates CVP. Trends matter more than absolute values. In right ventricular MI, high CVP with normal wedge pressure and Kussmaul's sign strongly support the diagnosis. Severe tricuspid regurgitation makes mean CVP unreliable. Waveform analysis becomes critical. CVP misuse persists partly due to historical precedent. Early goal-directed therapy targeted CVP 8 to 12 millimeters of mercury, leading to widespread adoption. Major trials, Process, Arise, Promise, failed to reproduce these benefits, and surviving sepsis guidelines removed CVP entirely. Marique's meta-analysis demonstrated its complete inability to predict fluid responsiveness. Yet practice inertia persists in many ICUs. The expert conclusion is clear. CVP cannot determine who needs fluids. It can only identify who cannot tolerate them. CVP is a marker of venous congestion, right-sided physiology, and the MSFP CVP gradient, not a preload marker. When interpreted with waveform morphology, respiratory variation, VEXUS, and integrated hemodynamic context, CVP becomes a powerful tool. Used in isolation, it is misleading and potentially harmful.